neonatology only, no?
Moving on with the next topic of the day is a panel discussion on an interesting topic to be moderated by Dr. Prakash A, sir. Sir is professor and senior consultant department of neonatology, Sri Ramachandra Medical College and Research Institute, Chennai. Sir has got many institutional awards for NRP, conducting NRP. Sir is currently the zonal coordinator of NRP. Handing over the podium to sir to introduce the topic and the panelist.
Thank you, Dr. Sai Sri. I think I'm here to present, moderator with the panelists, trying to find, just to find an answer to the controversies usually we face in day-to-day life. Not sure whether we'll be able to give an answer, or probably we may confuse you more also. Now we have a group of panelists who all deal with these babies, and we are going to, try to, get what they actually do. I mean, we are not going to talk about evidence. I think from morning we have been talking about evidence, and now we will be like more of, asking them with the, what they actually do in the unit. So I call upon the Dr. Giridhar, who is a professor and head in Department of Neonatology in Chetna Medical College. And he also deals with a lot of small babies. And Dr. Lakshmi, ma'am, I think she doesn't need introduction. She's been there. She works in one of the premier institutes in Chennai, Mehta Hospital. Dr. Prakash V, I think he's just on the way. Dr. Tejo Pratap, who is head department of neonatology in Fernandez Hospital. Now, with this extremely, experienced people, we are just going to start with this panel discussion. And I'm sure, there's, we are not looking at, what evidence are they doing it. Let's just capture what they do, because all of them have got good outcomes among extreme preterm babies. So we just have to know what is it, and sometimes there's no not one way to reach a destination. So we're going to now capture that. So to start with, okay. So we are trying to cover. We'll see how much time permits. Still, it will run as time limited show. So we're going to talk on resuscitation and not much touching upon delayed cord clamping and delirium CPAP, where it is clearly I don't think there should be any controversy in it. And then antibiotic after birth without risk of sepsis, type of care, incubator or warmer, and then extubation timing, PDA, and prophylaxis treatment. Then the methylxanthine treatment, when are we starting and stopping, TPN and enteral nutrition. And BPD, I think morning we had an excellent session with Dr. Naveen Jain. I think he, really enlightened a lot of factors. So it makes our job easy. And then about nitric oxide. I know there are much more than this. So now the panelists can, just see their phone and could just, answer this. What is the gestation? You could, I hope others do not take a QR scan. No, no, this is not meant for the audience. This is only for the panelists. At the end, if we have time, we will run for the audience. So this is what, you have the most important, doubt we have, or probably the question we have is, at what, of course, I think we have a session tomorrow on, perinatal palliative care. They're also covered in that. So we're just only going to ask, in here, what is practically, who all do they, intervene, right? So if answer, I'll go to the next. Yeah. So you could see that among the panelists, so around 24 weeks, 67% start resuscitating at 24 weeks and 25 weeks. Now the thing is, like what has been seen now is you have if you are planning to resuscitate, you should resuscitate actively and do not, deliver, think if the baby does well and then start to resuscitate, which will not give you a good outcome. So before delivery only, you need to plan, join. I welcome Dr. Prakash. Yeah, please join the. Sorry to have started earlier. Please join. Yeah, thanks. Thanks for coming. Yeah. So so that is the this thing there. So you could know that many of them do not go for 22, 23 weeks, but then a lot of this thing depends. I would just ask, probably Dr. Tejo, like what are the things you will consider when you're resuscitating periviable babies?
First thing is that how well we were doing in different gestations. So when we wanted to lower down our own periviable gestation, we have to reflect upon ourselves at what gestation we are reasonably comfortable. So once, suppose I am taking my cutoff as a 25 or 24 weeks. At 24, at 25 weeks, I am at least saving 60 to 70% of the kids or more than 50% of the kids. Then I can lower down my gestation and then start working on the same. Of
Excellent.
course, with the background being you have a good dedicated unit with reasonably good number of nurses and the technical people which are there. And while before initiation, obviously we need to talk to the willingness from the parents and ethically and transparently we need to show till now how we are performing,
Yeah.
what could be the chance for your
So most often we leave it to the parents, most are to, I think, the put the ball in the, to their court and to decide, because the reason, main reason is, if you actually see the outcomes and all that, the survival rate itself is quite less in these babies, but it is increasing. Now, the question now comes is, the controversy point is, unless we do, see, we cannot become successful with the first baby. So we have to start somewhere and keep moving on. But the problem is, the over so many decades, the neurodevelopmental outcome, there is no much difference in the, especially the adverse outcomes, has not reduced. But of course, then some of babies have improved statistically significantly, but the overall this thing has not come down. So that is a main controversy, when you take, some of them will argue that I would not resuscitate a 26, 25 weeker or 24 weeker for these reasons. I don't think we can say which is right or which is wrong. You just have to go by your own experience and go on. So this I already told you over a period of time. And now the other topics which is actually coming up is, adults born preterm. So actually they are saying now they have to take history of the, from the adults, like that, whether they had a history of prematurity, ventilation, because that actually has linked to not even lung disorder, but also with psychiatric disorders. So next question is, this is one of the things which we mostly have I think most of us will have an, the confusion here, like whether to start antibiotic when there is no risk factor for sepsis. Maybe it's delivered, but it is symptomatic, has got, has been on a severe respiratory distress, probably ventilated or on CPAP. What would be your antibiotic policy? Would you start, or you start and stop after negative screen, as well as culture, or only if screen is positive, only if baby needs mechanical ventilation? And yeah, if it's not listed, then I would ask you the question. Right? Can you move on? Yeah. So if you see this, okay. So again, this is another controversial, like thing here. So I think that I'm sure that a lot of units, they don't start antibiotics, and some of the units they screen, and if they find it to be positive, they start on it. So you will find, this thing there. So starting and stopping antibiotics, is not a negative culture, but what message which I think all of us like to drive is, probably Dr. Giridhar, you would like to highlight that, what important
Yes,
message you like to
well,
drive
ye-
according for the
yes, sir. It's a
antibiotic
very
policy.
important question. All of us actually have a dilemma in this population particularly because we know that the baby is symptomatic and the symptoms are going to be life-threatening symptoms like shock. I think no one would venture into not starting antibiotics. So, and we are in this population of 23 weekers, 24 weekers, 25 weekers, we always face this scenario in the first 24 hours, even later also. Baby is present with a extremely severe presentation, baby is present in shock. So it is very difficult to avoid antibiotics in this child. So what everyone, I mean, that my own practice is, I take a culture,
Culture.
I'd start antibiotics. Of course, I try to keep it as narrow as possible, and only if I'm very convinced that mother's factors are so highly in favor of the baby landing up with this problem because of infection, then I go for slightly higher end.
Higher
And
antibiotics.
when the thing is not starting antibiotics, when do we go for de-escalation? That is the
De-escalation.
only thing. That is the problem. The de-escalation is also a problem there, because we always feel that we have to stop, but it never happens in like that. In most of the units, they tend to continue till the baby is off some central lines, off something. I would
Yeah.
say the same it is for my unit. Even I tell them that stop also. The other consultant might veto my daughter also.
Yeah.
So it happens.
Actually,
So
the what answer exactly wanted we give. So, the other panelists have different answers. Like you could actually voice out. Otherwise, we'll go on. I think yeah, please.
Just wanted to say that again, like the message should be: suppose you have a baby who is born extreme preterm, just on CPAP, reasonably okay heart rate, and then baby is able to maintain at 30-35% FiO2. On those cases, definitely no
Yeah.
antibiotics as a
Okay.
prophylactic.
Yeah.
Okay. Without maternal risk factors and other
Yeah. Yeah.
things.
There's no mental risk
Mat-
factors. Yeah. Actually,
So the case where you have ventilation, high settings, severe PAH, maybe you are struggling with the shock with the inotropes and other things. You want to tell that in those cases you will start, and then you want to
yeah.
de-escalate or not
Yeah, I think
de-escalate.
the message is like, see, I think you can we probably not starting antibiotics, and then you
yeah,
could
and
wait
another
on,
thing I
or
just want to insist here, so just like in just minute more. I mean, if you look at the babies extreme preterm delivering because of some intraamniotic infection, as the gestational goes down and down, the chance of actually a maternal infection which has triggered that, preterm delivery is very high.
no,
And
actually, this is
scenario,
not a
yeah,
preterm
this is not,
delivery.
this
It's only
scenario does not
yeah, yeah.
fit
The
that
account, this
particular
scenario is
thing.
only delivered
Yeah,
because
but
of maternal
lot of
reasons.
times it happens that I
Yeah.
think they delivered because of spontaneous onset of preterm labor. They have a short cervix. And so these indications makes that start antibiotics. Even that is what recommendation is from AAB also. Like risk factors identification here should be easier.
Yeah.
So I think this is a very good scenario. I think if there is
Yeah.
severe
No,
maternal
that's why
indication
it is
only,
controversial. We
yeah,
will never get it.
it depends on the baby. Totally depends on the baby.
Understood.
Yeah.
Actually, I would like to ask the other panelists also. Have you had, suppose you start on antibiotics, have you had an experience of having a surprise of, having a culture positivity in babies like this, where you did not start and then suddenly you realize that, the culture, I mean, the baby grew something there because you just did a screen.
So, if you have an element of doubt whether to start or not to start antibiotics, I do start antibiotics. Because once a culture report is there, baby might not be there with you. Okay.
Yeah.
So, err on the higher side for extreme preterm babies, not so for 27, 28 weeks, but can consider to 23, 24, 25 weeks. I like to err on the higher side, other than withholding thing. But by antibiotic will be a basic thing like a
Yeah.
gentamicin or a simple drug, or if you have eye vaginal swab which adds something like that, something is there, you just write, or your antibiotic policy,
Just for our
whatever the culture policy.
psychological, this thing, you have given
Yeah, just for a
antibiotics.
safety reason. I should not feel
Yeah.
bad that thing. You know
Understood.
that,
Yeah.
yeah, you know your pattern of
You are
your
right.
bug in your unit. Every
Understood.
intensivist and neonatal unit will have a
Yeah.
pattern. You know what is the bug is there. And
Understood.
you will try to cover at least 60 to 70 percentage the simple antibiotic which you like to give, because 27, 20 weeks will not have much problems, but there will be a problem
Yeah.
in
Per
23,
year,
24, 25.
yeah.
Definitely, yes.
So I think what is the point everybody wants to insist is like you start or don't start doesn't matter, but once you start, you stop as soon as you find things are negative. Now the thing is, the most problematic thing is you don't stop after starting. Keep continuing because on the ventilator, baby has got lines, baby has got it. So probably that I don't think we have any disagreement or any controversy in that. But to start, I know this is a very controversial thing, which my unit policies usually we don't start on, but if you start on, we immediately stop. as soon as this thing is go on. Now, next is, type of care. Sorry for the typo. I mean, error. So the type of care things are there. So, sir, can I get it at the end, sir? Yeah, sorry. The type of care, if you are, you would like to keep the baby on the type of care you have. So, um, this you can choose multiple options, I suppose. Yeah, you can choose multiple options here. Yeah. So, now many times we think, like, especially I think I've gone to units where they do manage extreme preterm, but they don't use incubators. We have units where we do use incubators a lot. So I think this is again, controversy because you don't have evidence. Even for the previous question, we really don't have, too much of evidence to, say for pro or con. Whereas here in this, again, the same thing. In fact, for humidity, we are using it just like that. Actually, we really do not have an actually level of humidity to be used for each gestational age. So, yeah, so you could see here, I think there are some hi-fi units here. So hybrid InQ warmer, yeah, if it is available, I think probably everybody may love to use it because it has got the advantages of having this thing there. And I think humidifier, I think it's interesting to see the somebody with the open care, who opted for open care. Yeah, Dr. Giridhar. Yeah, could you please tell me that, like, what do you think is a problem in incubator? Because majority wanted to use
Yeah,
incubator.
see,
Yeah.
so let's be practical. We have to go with what we have. I mean, and second thing is what our unit is more comfortable with. So you know that the golden hour care becomes very important in this population. So the moment the baby comes, is a lot of handling will be there. Baby has to be probably I don't know, invasive mechanical ventilation. Lines have to be in place. Okay, so I think what my unit feel comes up comfortable is the babies are in open care. The manipulation becomes easier.
Easier.
I'm not saying that I'll stay on open care. I might shift the baby to the incubator once they are stabilized. Okay, but my initial part of it will be on open care.
Open
I
care.
think because and my hospital does not give me a INCU warmer. So let's be practical. Let's be pragmatic regarding what we are
Understood.
facing. I think that is the. I mean, this is the. I mean, what
Understood.
I
Yeah.
see only. I'm seeing outside also what is there. Of course, hi-fi units are there with me. That's their own answers.
Yeah.
So I start off with this and go ahead with that. That's all.
Okay, Dr. Prakash, could you just, or Lakshmi ma'am, both of you, like you using incubator, do you think there is an increased risk of infection?
We have started incubator, using incubator in the last 2-3 years. Actually, I'm very much for incubator and I face lot of resistance from the residents as well as the staff. But of late, now they are also falling into the groove. For one reason, I'm telling you, the fluid management is very easy. This baby is withering like anything in the open care system, then going high and down on fluid, the fluctuation of sodium, all that is very, very good if you are using a good humidified incubator. And I, over the year, maybe 2 years, have become quite comfortable with the incubator and the nurses' acceptance is also improving.
Yes, ma'am. Thank you.
So
Yes,
if you,
Dr.
if you,
Prakash.
if you see the units which has the best outcomes across the globe, you take a Swedish like Uppsala University, or you take Iowa, or you take Japanese entire people, they use humidification at some point of time. Iowa don't use humidification in the first 1 week. They manually keep the baby in a warmer for the first 1 week, but they start fluids 200 ml per kg on day
Yeah.
one.
Yeah.
None of us will dare to start at 200 ml per kg on day one. Uppsala uses 80% humidity from day one. Okay, and the fluid titration is around 120, 100 to 120 ml per kg on day one. The entire Japanese people, they start with 90% to 95% humidity. Fluid is 65 ml per
65
kg on
ml
day
per
one.
kg.
So the volume requirement dramatically decreases if you use a humidification on an incubator. Without humidification, there's no point of using an incubator, right? And the most important thing in our system is the infection rate is pretty high. And every 2 weeks once, we need to change the incubator. That none of us has that so much number of incubators, and I need to change it actually. What do I do in my unit is all the problems happens in the first 1 week.
First
So
one
I
week.
care the baby in the first 1 week in incubator, and then it becomes an open care warmer after the first 1 week. It's only for 1 week I use incubator, such that I can titrate the fluids a bit. The chance of PDA and IVH and all the steps are there. So I titrate the fluid very judiciously in the first 1 week, and then change to open care warmer, where the infection rate, I mean, you can
Understood. I think the point take to be considered is the controversies exist. You can use both warmer and incubator because both the what all people sitting have got good outcomes. You can use, only thing is probably you should keep in mind humidified incubator definitely reduces your need for fluid resuscitation or fluid requirement. Whereas in an open warm climate you do have. Do we have an RCT doing this? No, we don't have. We don't have really to prove which is actually one after
See, the
one is
problem is
better
in
over the
most of
other.
extreme preterm mammal. I mean, leave apart your 24, 25 weeks, you have good number of papers on this. But when it comes to less than 25 weeks, we have few papers on 24 weeks. We have to take it from your single center which do perform well. Maybe 10, 15 years later, we'll get an RCT and outcome. It's a single center based outcome is going to, because we don't see 21
Yeah.
weeks, we don't save 22 weeks, we don't save 23 weeks. But definitely we are going to save these babies after 15, 20 years.
Yeah.
Definitely we are going to save these babies. So all these units have been doing it for the past 25 years. They're not doing it now. Which is the protocol. They have started working on these babies almost 20 years before. Now only we have started thinking about working on these babies. So only if you start working on these babies now, we might be able to do something after 10, 15 years. So it's learning from a single center unit, and then they are the one who are supposed to, we can't do an RCT on these babies because
Yeah,
we're
that's
here to see these babies. So these centers who are showing a good outcome, they have to come with the RCTs.
Understood. I think many of the neonatal interventions are logical based actually if you look at, and then they try to find a find an answer to that, but generally we don't get it. Now, next is, other important controversy is the extubation of the extreme preterm babies. Like, you keep them on, I understand that 28, 30 weeks and all that, I don't think we have any controversy in that. We just extubate them, but in extreme and 27 weeks and all that, are we, know how many of us are bold enough to, actually extubate them and on a minimal setting? Actually, I didn't put that actually. Yeah, the baby is there. They are otherwise, if you take the counterpart of more mature babies, they are ready to be extubated. Now, are we what would you actually do? Would you like to extubate or give extubate at specific PMA or you take PDA into consideration? Yes. So I think all of us opted. All have opted for minimal setting. They'll extubate and one they take PDA into consideration. And may know the one who opted for a different opinion probably can answer the question. Yes. I expected that it should be Dr. Giridhar. Yeah.
Yeah. So my different take on this is this population with this less than this 25 weeker is different. I mean, 25, 24 weeker is different from a 27 or a 26 weeker. So I think there is a lot of studies, lot of recent studies which have clearly proven that the baby lands up with an extubation failure. Baby will have high mortality, BPD rates are higher, IVH is higher. Okay, so my take is these babies, a lot of babies are in minimal settings right after the first load of surfactant. So I think, but we have to see a period how they are behaving. So whether they have crossed that probable IVH risk period, which is maximal during the first 96 hours of life, whether the PC2 levels they're able to, with their own breathing on top of the SIME breast which they have, they're able to regulate that PCO2 levels. Of course, tidal volumes will give us an answer there. And of course, the baby's problems, the PDA, I mean, even though it can present after a week also, so babies are mostly on very bad PDAs during the first week of life.
Yeah,
And
we
I
are
don't know
coming
whether
to the
it's because
PDA
of PDA.
controversy
I
next.
think so. I think all this period is so my take is I generally extubate these babies. These babies, I'm not talking about any particular babies, this 25 weekers
Yeah.
at the end of first week.
End
Okay,
of first week.
I mean, that is how my population, I think I found this particular strategy to be useful. And if the baby never got ventilated for some reason, which could have happened, babies would have got shifted on CPAP,
CPAP.
and babies would have received surfactant. Then those babies, I don't intubate just for keeping them for more than 1 week. They
Understood.
got intubated. I will take my own time to extubate. But this is only up to 26 weeks. After 26 weeks, I mean, I have data to show also that
Yeah.
we do what universally is being practiced, but that's my own opinion.
Yeah.
I do completely agree with Giridhar. Right? So the maximum extubation failure is going to be within 72 hours, right? So try to avoid extubation. Definitely for less than 26, I agree with them. First 1 week, I'm not going to do. End of first week. But beyond this, there are lots of things. Is it a Sunday? I will not extubate. I will not extubate on a Sunday because number of people are going to be less.
These
Use
are all
it.
secrets of
Yeah, this is
neonatologists.
the
Okay,
truth.
anyway,
This is the truth. Everybody does
we'll
it,
have to
right?
give some reason on Sunday, but we
Right,
will not
Sunday, the
explain.
number of faculties are going to be in any unit. It's
Yeah.
if you take the major units also, they don't do it. The
Yeah,
number of
yeah.
faculties are less. And if it happens to be the registrar who's on duty, if the availability of the consultant is there, a lot of things plays a part because you have a threshold to reintubate, right? You
Reintubate.
wait, you see what is the problem, whether there's a bronchospasm, there's something else, there's atelectasis, you put NAME, try the max. But a registrar or a fellow will not have this. If he sees the retractions are grunting, he just puts a tube again, right? You should have a good team in the daytime, elegant, not like a random emergency, the baby pulling out the tube. It should be very, and these babies, if your unit is using fentanyl, you would have tapered and stopped, you would have
Tapered and
given
stopped,
medicine
yeah.
for it to start. So it's a fun thing. Definitely take time. And before us, I like wait for 27, 28.
Ah.
But intubate also if the baby doesn't require.
So actually, if you actually look at the, yeah, yes.
Additional point which in the first 72 to 96 hours that matters sometimes before taking a extubation decision is your acidosis. Because most of the babies, if you see on second day, -13, -14 is the normal basics which we will see in these cases. So on one side, you have to manage the weight, you have to manage the acidosis,
Yeah.
might be associated with hypotension.
Actually, I mean, I'm just saying that if otherwise is ready for any other baby counterpart, are you going to extubate electively or not?
This
Yeah.
baby definitely will have a metabolic acidosis.
Yeah.
It's unlikely this baby will not have metabolic acidosis.
But then
So
metabolic
until you're using
acidosis.
ringer lactate or isolate P, something like that, support to 20 to 30 ml per kg per day, this baby will have a base excess of -10, -12. You'll end up, you'll never get a pH of -5 for this babies on day 3, day 4. Just
Yeah.
what Lakshmi has to say because Pratap has answered so far. Everyone seems to agree with different opinions.
They have changed that. Oh.
If the baby is otherwise stable, like minimal settings, FiO2 requirement is less, the activity is good, and the respiratory efforts are good, I think 72 hours is what we wait and watch.
and watch.
And we are now very comfortable with NIV and NIPPV. I think that has really reduced the intubation time
Reintubation.
after that. That difference we are able to see now.
Actually, if you look at the guidelines, lot of guidelines says that do agree that there will be a lot of reintubation rates, but they do say that give a trial of extubation, and as Dr. Prakash and other people are saying that you should be very careful extubating depending on the capability of the unit and in the post-extubation phase, who's there and who's going to manage. Because that is and all will not, the books is not going to tell that. Probably these are all practical tips which, the other students
Yeah,
should
because
take.
I used to be very think 3 years before. I used to pull out the tube after 3 years, minimal settings. I used to be there. As you grow mature, you see what is happening and what you see in other units. After I went to, Tokyo for some time, they wait for 7, 10 days.
Yeah,
They
yeah.
don't pull it out, right? They know it's a minimal settings. That's nothing.
No, that's what even the good centers got good down, got different extubation,
Yeah,
criteria
right.
and
I mean, you should have a
protocols.
fixed protocol in a unit. What is
Yeah, that's
good
right.
for a unit and what you're capable of managing, you should have a standard protocol in a unit. It might not work in other units. Some people
Yeah.
might feel foolish. It works in
Yeah,
that
actually,
unit.
it's right because you suppose you're going to keep them intubated, but you're not going to land up with too much of VAP or ventilation
It's not
associated.
an individual preference.
Yeah,
The
that's
entire
right.
unit Involve the nursing staff in the decision.
So that's right.
Residents who are going to be there, how confident are they to monitor? I think it is a collective decision,
Decision.
and we all decide during the rounds, okay, this baby will try to pull it out and see.
Understood. Thank you. So now the most, we could never answer this question of PDA closure. I really do not know so many thousands of babies they have been undergone treatment. Still, it is so controversial whether to treat PDA or not. So let us ask the experts, like what do they do when they have a PDA regarding the PDA closure? I know you just have a PDA in that baby, ma'am. Uh, if it is applicable, I think this I thought is only one. Oh, okay. No, ma'am. Yeah, you can. If it is allowing you, I think this is made for one only, I think, ma'am. So, ha. Right. So you can see, the controversy is equal, like whom to treat and not to treat. It is, it's balancing out low. So it is a perfect, things there. So you can find this actually, a lot of, evidence have come, but really they could not really answer this question whether treat or not, I think it is like, again, it will be an individual preference, and you have to, maintain your records and, take a call on that. So actually, yeah, is anything that you would probably, yeah,
Yeah,
Dr.
that's even if after 15 years you're going to this topic, we'll discuss the same discussion actually.
Correct,
It's been
that's what
never-ending
we'll have,
topic actually, because
because it's probably is it
both the
physiological.
treatments have shown better outcomes. So people who have been doing some PDA without they have not given any importance to PDA, they have been able to manage with PDA. And there are units they treat if they see a PDA. That's it, not even the size, right? They see just the PDA, they treat it. So both the units have the outcome. It depends upon what you're comfortable with and what you've been used to, and the choice. Lot of people use paracetamol. I use Brufen since indomethacin is not available. IV Brufen is available in India, so it's available.
Yeah.
So I use IV Brufen. It's individual choice,
Individual
and I
choice.
can't say it's not to treat or to treat. It depends upon
So let
what
me
the
just
doctor.
present some of the things. I mean, we'll just finish this and then we'll discuss further on it. Like, suppose if you're going to manage, asymptomatic PDA, and how do you actually manage it? You do a restrict fluid, and that is HSPD. I mean, there is HSPD on the echo, but baby is asymptomatic. Now, how do you? I'm sorry for the spell error. So, how do you manage? You restrict fluid with diuretics. You have Brufen, paracetamol, or either of the drugs you use. You don't actively intervene until it is symptomatic. So the thing is, maybe I'll just go through some of the evidence and ask the panelists to have an answer to that. Yes.
I think 10 years ago, 10 years ago, I have used prophylactic indomethacin in 25 weekers, 26 weekers and below, and I found the outcome to be excellent now. Then IV indomethacin is just gone out of
Out of
so
work,
we
right,
don't
yeah.
get to see it at all. So now what we practice is, it has changed a lot in the last 2 years because most of our residents are very well echo trained. If they are not echo trained, I will not take chance, wait till the next morning. The baby may bleed in between, have a pulmonary bout of bleed within 24 hours, and I may end up with a sick neonate. So in that case, I wouldn't have taken a chance. I would have told them, chalo, give off a dose of para by 12 hours, keep watching, keep looking at the baby and all that. So now that our team is more or less very well trained to look for a duct, so our constant surveillance, we are able to
Understood.
reduce our closure of duct. And sometimes if it is going to happen in a day where the resident is not very adept in measuring and all that, we use a para dose by 12 hours. Okay, give it off one for the night. Let's assess tomorrow and then we continue.
Actually,
We
let
are
me.
better to paracetamol. Once given,
Oh,
we don't
okay.
continue all the time. We take our time to assess and then decide about it.
Just hold on. Let me present some of the, the evidences which is there, and this is come in 2009 Journal of Pediatrics. So here they have got moderate to large PDA, and they had the babies who got HSPDA, and looked at the how does the treatment work, and this is their treatment protocol. You can actually go to nicely given. The protocol for the treatment is nicely given. And then, they also have a rescue treatment if they don't initially respond. Either they are in conservative therapy or on, drug therapy. And then they actually found there is no benefit because there's no difference in the PDA ligation or presence of PDA discharge. Did not improve any pre-specified secondary outcomes. And sometimes they found that to harm in the form of delaying the full feeding, and higher rates of late onset sepsis, death in infants at less than 26 weeks. Another question which, along with this, I would like you to answer is, how many of you actually keep the baby nil per oral when you are treating for PDA? We can start with Dr. Prakash and move on. Just answer, would you like to keep NPO for this thing? And what do you think about this? And I think we also have the other recommendations, which actually do not straight away say that you treat as soon as you see PDA. The Cochrane review, this thing which has come recently in this e-clinical medicine. Now everything seems to be, but it is very much, like yes or no type. I don't know why is there so much of confusion there. Yeah. So now this is like now this is open to the experts. Like one is why do you? I mean, despite having so much of this thing, like what is your individual experiences? And also they're saying that the PDS there, the management could be actually the keeping a higher higher ventilator pressures, like on CPAP, you can have a higher, CPAP pressure, or a higher in NIV on a higher PWP with judicial use of fluid. And also very strictly they say do not restrict fluids, and you could use diuretics and try to tide over instead of trying a drug therapy. So there are a lot of things there. So now you can just share your your experience, and also add on, do you actually keep nil per oral, and when you actually
Definitely
treating a
no. It's
PDA
nil per oral, no. Yeah, we will continue the feeds, no question about nil per oral thing.
and
And
drug of
fluid,
choice.
fluid restriction, definitely, we'll try to keep at 150, not more than 150 ml per kg. Definitely, the baby is on 180 ml per kg. We'll try to come down to 150 ml per kg. We'll not go beyond 150 ml per kg for baby. And with regards to what type of PDA are you treating, we just not see just your diameter as well as LA ratio alone. The left ventricular diameter dimension as well as your right pulmonary artery flow velocity, and more important is your peripheral perfusion is more important. If you see a renal artery, is there is an absent reversal, then definitely you know that it's a significant PDA. You try to treat all these things. It's not just seeing a PDA or treating it. It is significant. It's going to cause a perfusion. The most of the time, what happens in our scenario, we see the chance of pulmonary edema later on develops a pulmonary bleed.
Bleed.
That's the thing which you are more worried or concerned about it, right? That's the reason why you keep your PEEP a little bit high. But generally, I'm a PEEP-phobic. I don't generally keep PEEP more than 5.5. I just don't keep above. I'll try to go for an NAME sort of thing and manage the things. And there's no contraindication. Blood transfusion don't need to do, just like if transfusion don't need to stop the feeding. PDA doesn't require any stoppage of fluids. Check your diastolic flow. Obviously, your diastolic flow is going to be very low. That's more important for us. It falls dramatically because of white pulse pressure. We are so much concerned about your diastolic pressure. We try to keep it at the fifth centile, at least your diastolic pressure. We have a close watch on that. Those are things, minimal things which we do. And it's not that we are going to give a complete course of Brufen or paracetamol. We check echo every 8 hours once. Okay. And if there is a closure is there, we stop. Even with one dose of Brufen, extreme preterm babies, the PDA gets closed. Definitely there is a bidirectional shunt. We dare to touch the PDA. We are not going to touch it. If there's a minimal shunt, less than 30% shunt is also there, we're not going to close the PDA. We are going to wait. There are situations, right? And diuretics, it's very controversial because diuretics, we know it decreases the closure of PDA rate, right? But there are some scenarios we have to, the baby is edematous, putting on weight dramatically. We try to show one or a couple of shots of diuretics as low dose. I don't give 1 mg per kg, I give 0.5 mg per kg for these small babies. But with long-term diuretics, definitely no. It's a 1 shot or 2 shot of diuretics. That's what I practice.
Okay. Any other different opinions than what he has told? If you agree with this, then we can move on to the next. Is there anything else you'd like to add on?
See, again, it is context specific. The thing is, getting 8 hours echoes, even though it is pipe dream for a lot of units. And I'm not a hemodynamic expert. I think Tejo, we know, Kiran is there. So these people are hemodynamic experts. They will be exactly able to define the HSPDA. What I can do from my side is tell the diameter and the LA-IDIC ratio. That is what my students also let me know. With that, taking a decision is difficult. That is number one. Second thing is defining what is symptomatic. Okay, a baby who's on intubated on high ventilator settings, background being RDS with a PDA, I think whether after 2 days, maybe might have had only one dose, suddenly there is a slight deterioration. And if you go to the X-ray, you look at the haziness, whether it is actually RDS which is sufficiently not improved and causing some problems or not, whether PDA is contributing to that, that is a query. And second thing is your perfusion. Most of these babies have low perfusion, and my personal experience is it depends on the phenotype also, because a lot of these babies have a lot of pulmonary hypertension. I think treating pulmonary hypertension, I think a lot of times they look at the PDA. These PDA is 50% flow, and to quantify that is also not accurate among all our residents, and they land up starting some treatment which could be actually catastrophic for the child. So I just observe the baby. The baby is not very symptomatic. Of course, symptom, I have to be very convinced that it's because of PDA. Then I tend to observe these babies, which are large duct, whichever remain for the first 3-4 days. Then only I take a call whether a treatment has to come in. Okay, so that could be individualized also a little bit. And most of the times there are contraindications for starting neoprofen. That is what I see, because either creatinine level is on the higher side, babies because a lot of these babies are SGA, fetal growth restricted, they have platelets on the lower side, they have a minor bleed, And I mean, if you ask three people to quantify the amount of IVH, one would say grade 1, one would say grade 2, another might say even grade 3. And in echo, we don't get, at least for neonatal echo, we don't get good backup from the pediatric cardiologist because they are not in tune with what we are doing. So all these scenarios will make a factor whether we decide on PDA. Of course, as Madam said, I think it is going to be a joint decision. Talk to the nurses, what is happening. At least you go to your seeing rounds and see, I mean, nursing chart, whether it has an escalation in care. If you're convinced that it's because of PDA, I would treat them. Otherwise, I would just wait and watch, see if I'm very convinced that it is only the PDA which is contributing to that before I take a call on starting. And most of the time, it's going to be only paracetamol because not because I'm fond of paracetamol, because of contraindications to starting of ibuprofen.
I think the PDF you start talking, I think the whole day will not be enough, and I don't think
Maybe I
we'll be
think,
able to
I can
convince.
just only put 2 words.
Yeah.
First thing is that in most of these studies, whichever we are quoting, open label treatment was very significant. So that was the major issue with all drug detect, tolerate, all these things. That was the major contamination. So ultimately, what do you want to achieve? Is it the short-term benefits or the long-term? Just satisfying seeing on the echo that it is closed, or long-term whether the baby is having the better outcomes with this. So that we are still not clear with.
Yeah,
whether
that's what
by
that's the controversy
Yeah,
which is
maybe
there.
a early symptomatic HSPDA with early symptoms is the time where we need to take a decision. That is the major thing.
So I think they already put up the time now to indicate that we are running short of time. Yeah. So now probably yes. So quickly into the prophylactic use of caffeine and probiotics. This is an you need to type the answer. It's a descriptional answer, and I think one of I will probably pick up Dr. Tejo to answer this while the other people and keep answering this question.
So we are using prophylactic caffeine for all the babies who are less than 30 weeks and less than 1.25. So as a rule, probiotics, we just started it 2-3 years back. And again, the controversy exists, which we have to use it. We have to wait for the which probiotic, which we can use it in our own scenario. The major problem with this is that these are all FSSI approved one. We do not have a DGCA approved proper probiotic with a good high grade quality where when you mix it in the milk or in the water, whether they will have the same amount what they are measuring it at the
research.
industrial. So that is a major issue. But though the recent level of grade of evidence has been downgraded to the probiotics because it has percolated into the units, we are ending up in continuing it. We just need to wait.
Actually, the AAP also sometimes they recommend that less than 28 weeks probably
Yes.
to avoid the probiotics because that can actually cause infection. Anyway, we'll see. Yes. So you got, yes for caffeine, no for probiotics, and others to answer like prophylactic caffeine. And yeah, so uniformly everybody agrees that caffeine should be given. So I think there's no controversy. It seems to be there. And probiotics is yes or no. So probably you can take up. Now, next is, if you're going to take the choice of, methyl xanthine, suppose you have this thing available. So what would be your choice of methyl xanthine you would use? You do have multiple choice here, yeah. So all of us use, I think, yeah, caffeine. I think the major the advantage, I think all the panelists would agree that it's got lesser side effects. But actually, if you actually see the evidence to really comparing these two, you don't have. And in fact, some of the things which they already available says that they really cannot really differentiate which is a better drug. Now, we are just using caffeine only because has got lesser side effects compared to, so logically, we actually use aminophylline. So
We have come from the era of aminophylline actually. We have used left and right aminophylline followed by thioped drops for all preterms who go home, and we continue it orally. It was very difficult for us to transit from aminophylline to caffeine actually because of the cost and other things. So now we have gotten used to caffeine very
caffeine
much
as
and a
a,
single day dose and lesser side
I don't
effects.
understand why it should be so costly,
Yes,
but
so
anyway,
we have
caffeine,
accepted it.
coffee is so costly, yeah. So,
So,
yeah.
for apnea of premature, definitely use caffeine only. No, it's no question of aminophylline. When it comes to BPD spells, right? At the time we stop caffeine and we switch away to aminophylline infusion and
Yeah,
stuff like
actually,
that.
I have a question
Yeah.
after this, actually, regarding when will you stop? Now, this is what I was just telling you, like, actually, there's no real data to say which is actually is better over the other. And now, next question is, this is the other thing which we have, when will you discontinue the aminophylline? So I could take Dr. Giridhar to, answer, the others could just take the
I
choices,
think
yeah.
here it's a lot of variation with what I do also, because I'm also not sure.
You yourself controversial
Yeah, see,
within
but
yourself.
what is my thinking is I tend to continue them till term age. Because the basic reason is these babies, irrespective of whether you stop at 33, 34, 35, as what the guidelines mention, the incidence of intermittent hypoxemia is very high. And we know that, a lot of literature is there saying the adverse effects of intermittent hypoxia on the ROP rates and neurodevelopmental impairment. And we know that caffeine works for just this group also. And now there is when studies which are coming up, which are actually looking at whether caffeine needs to be continued at home and what duration needs to be continued also. Till they get answers, we cannot be dogmatic in saying that caffeine is harmful continuing for babies at the prolonged point of time. Could be
Understood.
the thinking could be the other way around also. So yeah, guessing itself can cause issues, but I am totally for continuing for a longer duration. I don't want my babies to come back with some problems. I think it is me, but that's it.
So just to highlight something on this, I just for want of time, I think what happened? Okay. Yeah, so we have equal answers, some other options. Let me see if I can just get some time. Actually, if we actually look at the, regarding the cessation of caffeine, they've done various protocols have been followed. Some of them just stop once they have no episodes of hardly any episodes in the first 5 days. They just stop at that point of time. We actually stop at around 33 weeks and observe for a week and things. I think we have a lot of things, but we really do not have an answer to the. But there are various protocols. You can follow any one of it. Is the controversial point there. So baby, I'm sorry to skip because I think Dr. Saish is getting upset about me continuing. So baby delivered, after working hours. Now, how do you start TPN? Like, the time of initiation, amount of protein, route of administration, because this is now immediately after delivery, what do you do? Like, the not during the hours where everybody is working, then the out of hours, do you really start on therapy? So you got various options, like if answer, yeah. Oh, I think I've not got the answer yet, yeah. Right. So I think most practical thing could actually here you can choose multiple options, I suppose. So like most of the unit, I think would be easier to start on some amount of protein and probably dextrose is the easiest thing to do. And in fact, the some of the places I visited also abroad, they actually give start 3.5% with 10% dextrose. They have a ready-made solution. So I think most practical would be that, but I'm not sure whether TPN you can start any time of the day, which I feel practically it is impossible unless the panelists disagree with me. Yeah, practically is difficult to do any time, but I think there's one person has opted for aggressive nutrition. I think the may know who's who opted for aggressive nutrition. Okay, let's calm down. Okay, right, right. So yeah, we'll go to the next one. So when will you start feeding and type of milk if MOM is not available, volume of initiation and incremental volumes. So this is again, yeah, the descriptive. Okay.
So clinically stable, first thing, without any antenatal Doppler abnormality or FGR status. Type of milk, obviously, if the mother's own milk is the choice. Second choice will be your either donor human milk. If it is available, that's the second choice. Third choice will go with the formula in our unit, but that's very rare because we also have a milk bank. So volume of initiation with very 10 ml, 10 to 15 ml per kilo in the beginning. Then we'll keep upgrading it as in much. And we'll go with 20 ml per kilo if the baby is otherwise is a reasonable reward.
I think that most of you may not have much of controversy in this. I think we have to start feeding, but I think probably I may have a difference that even with the Doppler anomalies, I think we can start on some amount of feeding, I think now with the present evidence, and otherwise, most of it you can have a unit protocol on how much to start and how much to go, because really nothing has proved for or against in regard to your volume of initiation or incremental in feed volume. So next would be like, initiation of KMC in a baby, in extreme preterm babies. When do you start, doing the KMC initiation? I'm sorry, like, because running out of time, I'm just moving a little faster. I know we have a lot of controversies. Lakshmi ma'am, could you take that question? Others could just answer the. So when would you start games in a unit, ma'am? In a baby who's extreme preterm, as soon as they achieve, once they become 28 weeks, irrespective of the weight, or you want both weight and gestation of more than, so that's not 100 grams, that's 1,000
No, as
grams.
soon as the mother is available and willing to do KMC is one issue. And the
No, in a
second,
baby who's extreme preterm, say for example, 26 weeks,
extreme
25 weeks.
if they are out of their invasive ventilatory support, maybe just only on a HFNC or so, we still do early. We don't wait for a weight to gain above 1 kilo or the gestation to cross 20.
Oh, that's very nice.
We
ma'am,
do it
actually.
quite early.
Well,
It
all
is
other
only the
panelists
out of
agree
free
with
of the
that.
mother, which is most important.
Okay.
And most of the babies on HFNC, on CPAP, they are comfortable.
Okay, then probably we must try in our unit. We asked you initiate at 28 weeks. Is that right, Sarsa? No, no. It's
Yeah.
not at 28 weeks.
I was surprised
Actually,
to, if I was surprised to say that, in Swedish, for 22 weeks, they do it on
they
day
do
one.
it on day. Yeah.
They do it on day one. So we don't have the guts to do it on day one. So once a baby is hemodynamically stable, even on ventilator, we do KMC. But the problem is you require 3 staffs for it actually. You require a lot of staffs to monitor that actually, because so many gadgets, your umbilical lines, your umbilical artery will be there, your ventilator circuits will be there, pulling in through this. So we generally tend to do it on third day, provided baby is hemodynamically stable. If the baby is on inotropic cephalon, definitely yes. No, we are not going to do it. The baby is
Only if it
hemodynamically
is stable. Yeah.
even if it's on TPN as well as ventilator, we do it. But it requires judicious. They may not be able to do for 6 hours, 8 hours, but we try it for a couple of hours. That's it.
Okay, good. So, okay, my mention not mentioned here. Okay, that means probably you will use it. Yeah.
No, again,
I
we
think,
have to discuss with the team of nurses how busy the unit is, how free are they to spend time with the mother, sit along with the mother, making sure these lines don't pop out.
Don't pop out. Yes, ma'am.
So we decided on the rounds whether baby is going to get KMC today or not.
Understood. Okay. Now, I think ventilator strategy, probably, I think that was dealt very much detailed by Dr. Naveen Jain today morning. I think we had, and also that I don't think we have time to really discuss that. That is a huge, discussion. Quickly on to like probably which all you consider as BPD mimics, probably Dr. I think somebody, I mean, one of you can just answer. We'll move on to the next.
My major BPD mimic is postnatal CME infection. Babies seem to be recovering well. After 3 weeks, has a sepsis-like situation with escalating ventilator settings. And most of these women, I mean, my personal experiences, I think our CME positivity rate in this population of extreme preterms is very high.
Actually, we
Because,
do have, but we're really confused, now looking at it, like, is
I
it
mean,
really
what-
causing
yeah,
or
yeah,
is it a
that's
red
what I
herring?
think whether it is actually that is contributing.
Yeah,
is
that
these
is,
babies are symptomatic and they seem to actually do well after starting on some medications,
understood.
especially if they're associated with some cholestasis, thrombocytopenias, they improve. And a lot of times we tend to treat them with antibiotics and all. So BPD mimics, I think the major mimic here is going to be your CMV infection. Of
Like
course,
others
I doesn't only, it's not mimicking, it actually complicates
complicates
worsening
the
of
system.
BPD. I mean,
Others
very
could just
definite.
say any other BPD mimics you have, like other than
Reflux, sometimes
reflex. Okay,
feel
ma'am.
baby
Next,
having
Dr. Prakash, any other BPD mimics? And then Dr. Tejo.
Usually see the 3 things I usually tell students to see is that one is CMV, BPD collaterals, and GERD is the other thing, and MBD, metabolic
Okay,
bone
right.
disease.
Okay,
So these
thank
4
you.
profiles we need to do it whenever there is a baby who is stuck on the support.
So this is a very ventilation strategy. I think we won't go into it. And quickly into nitric oxide. Is there a role in preterms, like regarding nitric oxide?
In this particular
This is
population, I think there is a big role. I
Yeah.
think people, I mean, we see a lot of pulmonary hypertension in 23 weeks, 24 weeks. Only whether we need to treat them. I think most of these babies sometimes, I mean, do well with your adequate lung inflation with surfactant. And so, if I mean, of course, if OA is going to be high, when what is the cutoff? No one knows now. I follow cutoffs of around 15. So before I start them on nitric oxide, 60% if I do, I start them on nitric oxide.
So if
But
there's no response, do you immediately come
yeah.
down or do you continue with it?
So it depends upon your lung condition. If your lung is bad, you try to, as Giri said, that you try to recruit, treat the cause and stuff like that, right? And there is a group, most often it happens in 23, 24, 25 weeks where you have early onset sepsis, right? So where the incidence of your PPHN is pretty high actually. Okay. So
Yeah,
this
sepsis is
babies,
known to increase
yeah,
your
this
pulmonary
babies,
hypertension.
this babies have a definitely as a PPHN, definitely will have PPHN where you have a decent amount of recruitment of the lung and pressures will be pretty high.
Dr.
But
Prakash,
very
yes,
cautious in this group is that I more than 3 parts per million. I'm speaking about 24
Yeah.
weeks. We don't go 20, 20. So we maximum we go up to
Go to
10,
10.
but never go more than 10 for these sort of group. That's
I think
what
Dr. Tejo wants to say something.
Yeah, just two
Yeah.
things there. One is that though it is not FDA approved drug, off-label usage across many of the Canadian and US units is quite rampant with the nitric oxide. I do know some of the students who have come from there doing the fellowship, they say that they will even start while resuscitating in the beginning in the delivery room also for these 22, 23 days. Recent article, I think last month only, where publication is there from the JAMA that I think everyone can see it. So they said that, I think it's not a RCT once again, but from their study group,
Yeah.
which they were able to publish. So anybody who is more than 60% FiO2, if you are able to give those children the INO, definitely there is much role in terms of reduction of the duration of respiratory support. It's not about BPD and other things, but duration of respiratory support is lesser. So you're extubating it a little earlier.
So the worry about nitric oxide and IVH, Lakshmi ma'am, do you want to say any worry about your
Nitric oxide
side and the
again,
intraventricular hemorrhage? Many of the time when we start, they are worried about that because it causes platelet dysfunction and can cause IVH. So what is your take on that?
Nitric oxide, I wonder whether it works. Time and again we started, but we get a transient improvement in oxygenation and we don't pull it out at all. It goes on and on. So really, are there lung is there enough to take up nitric oxide? We really do not know. But when to stop again becomes, no, they become very reluctant. They'll say one desaturation and
Desaturation.
because of this will continue. And so it goes on and on. So I
Actually,
really
one,
do not
many
know
of them
whether
the unit sometimes it gets switches off. You won't know.
found out is when we use this earlier nitric oxide, no, with great difficulty, we stabilize them and bring them out. By 36 weeks, that BPD, bad BPD is waiting for us. It's not going to be smooth at a later date also. So I wonder whether we are prolonging to 36 weeks and getting into more trouble.
Yeah, that's
Yeah,
okay.
I like to differ with ma'am actually. It works actually. Even currently 24 weeks baby is an INO actually. So it depends upon the unit policy. You should know what you're doing. So there should be a universal policy when you're supposed to wean, at what cutoff you're going to start, and what is acceptable level. So for example, if you're ventilating, you're doing INO for sepsis, that's not going to have a long-term impact, right? It's a transient until you buy time. If it's going to have a hypoxemic respiratory failure, that's going to have a metabolic acidosis, pumping is going to be poor, your shock is going to get worsened. For buying time, correct the hypoxia first. So for buying time, it works. It's not a long duration, like 10 days,
Yeah.
the baby is stuck on INO, definitely when the problem is there. Yeah.
Okay, thank you. I think the message is like, nitric oxide may or may not work. And I think we're into the last 5 minutes. So into the conclusion part of it, I think most of the controversy will always remain controversial. I think you need to develop your own guidelines and probably take from your experience as you get on. But you keep get updated. I think we should have a registry, and then you should have a central registry to really, and all of us should share data, to really know, because Indian population may differ from the other populations. I think we have to all join together and then, share our true data for us to really actually know what works well in our Indian population. Well, nursing, and also most of the time, what everybody is trying to say is it may be individualized. Not every time evidence gives an answer to that specific baby. So the controversy remains controversial here. We could not actually, most of the questions we saw here, I don't think there's one answer from the experts who have been dealing with this baby regularly. Just if I have the one time, because Dr. Ellison sir wanted to Just ask one question. If you still have that question, otherwise we can. Yes, sir. I think because he asked, I said I'll give time in the end. And after this, we'll close this session. Yeah.
Extremely preterm baby, where you stop the antibiotic after cultures are negative. So how do you monitor for sepsis again? Do you routinely monitor for sepsis, repeated doing CRPs in asymptomatic babies?
Yes.
Maybe
So,
ventilate on ventilator, lines are there.
yeah,
Lines
so-
are there.
yes, the experts, like the question is, how do you monitor for sepsis in a baby who has got the
Only
risk factors
clinical
like
setting,
on
only clinical
line,
setting.
line is in and you're on ventilator and
So-
all that.
If culturist growth is there and if there is some lines, I never dare to stop my antifungal and keep the baby on gentamicin at least for the baby. Okay, if there is definitely there is some symptom like that, until I keep until the umbilical line or PICC line is there, right? I don't continue thing. If the lines are there, I stop the antibiotics for the baby. If the line is there, definitely most units they continue antifungals. If the antifungals until the umbilical line is there,
Prophylactic,
majority of units.
And that itself is another topic. Yeah,
So
Dr.
the-
Giridhar will finish with
the
Dr.
one is-
Giridhar's.
Yeah, one more thing is usually the practice is once the blood is sampled for some other reason, why don't we see a CRP? So that is a practice which is very prevalent. Even if you don't want to do that, and CRP is mostly positive. And having a and when we see the baby will be normal, and the baby and the antibodies would automatically got escalated. I think I mean,
Actually, one
it
of
is never,
the-
it's not going to end.
In
anywhere.
one
I
of
think this
the
is normal.
Japanese units in this thing, when they presented, actually they do screening regularly. I was finding it very, this thing, surprised to look at that protocol. I think again, I don't think you get an answer. Somebody believes CRP supporter, some are CRP non-supporters. So with that, I think should we come to the conclusion of this event, Uma will now next will throw me out of this podium next. Yeah, yeah, yeah. Yes. Thank you so much for your patient listening. Yeah, hope it was may not be useful, but probably interesting. Yeah, thank you.
Thank you, Dr. Prakash, sir, for moderating this interactive session and esteemed panelists for an engaging and transparent session. I now request Dr. Prakash, sir, to felicitate Dr. Tejo Pratap, sir, with the memento.
எஸ்கேப் பண்ணுங்க சார் அது சிஸ்டம்ல பண்ணோம்
Dr. Giridhar, sir,
இதுவா
Dr. Prakash Vinayagan, sir. Now request Dr. Lakshmi ma'am to felicitate Dr. Prakash, sir, with the memento. Moving on to the next PM session, we have Dr. Ramachandra Moham for judging the sessions.